Jacob. I'm a final year medical student at Lancaster Medical School. Thank you for joining me today for part 5 of this cardiology series, where we're going to be talking about hypertension. If you haven't seen parts 1 to 4 already, make sure you check them out. I highly recommend it. And as far as today goes, I hope you find it useful and maybe learn something that you didn't previously know. So, with all that being said, let's get right into the video. So, like always, you know, I like to put a lot of emphasis on understanding basic physiology first before diving into more complex pathophysiology. So, with that being said, let's have a look at some how the nervous system can regulate blood pressure. Okay, and before I move on, I just want to mention we're going to be talking about some specific cardiac centers within the brain, and their particular location is within the medulla oblongata, which is part of the brain stem. And the example we're going to look at here is if the mechanism would be activated if an individual's blood pressure was lower than it should be. And I just want to mention as well this diagram. Um, I rate it quite a lot because it looks at all the different factors which contribute to mean arterial pressure. Now, I actually have a new equation for you, something we haven't talked about in the past, and you can actually work out mean arterial pressure. That is equal to all within brackets systolic blood pressure plus 2 times the diastolic blood pressure, and then you close the brackets and divide all of that by 3. Okay, so let's look at this mechanism. So initially, the baroreceptors, so the pressure receptors, are inhibited. So the baroreceptors are located in the arch of the aorta and also in the carotid sinus. The NTS center, so the nucleus tractus solitarius center, is stimulated. It can be stimulated, particularly by the posterior nucleus of the hypothalamus. There can be neurons which extend from there and stimulate the NTS. But then the NTS is then going to send impulse to the cardiac accelerator, vasomotor, and cardiac inhibitory centers. The cardiac accelerator center increases heart rate and stroke volume, and it does this because sympathetic nerves extend and release neurotransmitters such as noradrenaline, which act on specific adrenergic receptors on the heart. And then if we think about the vasomotor center, you're going to have sympathetic nerves extending from there. And through a similar process, by releasing neurotransmitters such as noradrenaline, for example, they're going to act on alpha-1 adrenergic receptors on blood vessels. And that's going to, basically, if we jump down to here, the smooth muscle within the tunica media is going to be stimulated, causing vasoconstriction and hence a decrease in radius of the blood vessels, an increase in total peripheral resistance, and therefore an increase in blood pressure. Okay, and how the nerves from the cardiac accelerator center work, they basically stimulate the sinoatrial and atrioventricular nodes and also directly stimulate the cardiomyocytes of the myocardium. And that's why you have the increase in heart rate and contractility. And it's through something called G stimulatory, that's what the S stands for, signaling, and that leads to the phosphorylation of calcium channels. So you have more calcium entering the cells. Okay, and then initially up here, the cardiac inhibitory center is inhibited because we don't want that to be activated, because normally you'd have parasympathetic nerves such as the vagus nerve extending down from there, and that would ultimately lead to a decrease in heart rate and contractility and peripheral vasodilation, which is not what we want if the blood pressure was lower than it should be initially. Okay, so I hope that all makes sense so far. So let's look at the hormonal control of blood pressure. I'm going to use the same example. What would happen if an individual's blood pressure is low? So we need to form this chemical called angiotensin II, And how that's done is specialized cells called the macula densa, located within the distal convoluted tubule of the nephrons within the kidneys, detect reduced tubular flow, and therefore they release this substance called renin. Okay, so bear that in mind for now. The liver produces something called angiotensinogen, okay, which enters the systemic circulation. Renin comes into contact with the angiotensinogen and acts like an enzyme, um, and basically cleaves off amino acids from angiotensinogen to form angiotensinogen 1. Angiotensin converting enzyme ACE, which you might be familiar with, then converts angiotensin 1 into angiotensin 2. Okay, an ACE, the enzyme, the converting enzyme, it's mainly located in the lungs, but it's also located in vascular endothelium and the kidneys. It's located in the heart and also the brain too. It's just less abundant. It's dominantly in the lungs. Okay, and then the functions of angiotensin 2. So it's not actually put here, but angiotensin 2 also it's a peripheral vasoconstrictor, so that'd increase systemic vascular resistance and therefore blood pressure. Um, but another two things what it does, it stimulates zona glomerulosa cells of the adrenal cortex, which leads to the release of aldosterone and mineralocorticoid hormone. Also stimulates the supraoptic nucleus of the hypothalamus, which causes the release of ADH from the posterior pituitary gland into the systemic circulation. Let's talk about the action of the subsequent action of aldosterone and ADH. So ADH acts on these receptors called V2 receptors, which causes aquaporins, so tiny channels, to fuse with the collecting duct of the nephron. Water is then reabsorbed into the epithelial cells of the collecting duct, so you're retaining onto that fluid. Aldosterone binds to a specific intracellular receptor to form a transcription factor complex, which leads to the reabsorption of sodium and hence water in the distal convoluted tubule and collecting duct. And the channel through which the sodium and water are reabsorbed is called ENaC channels. They're a type of specialized sodium channel, essentially. And aldosterone is binding to specific receptors on specialized cells within the nephrons of the kidneys called principal cells, and the other main cells in that area are called intercalated cells. Intercalated cells are more involved with acid-base balance. And then we need to talk about hormone which does the opposite, because we need something to um, balance the blood pressure out, because otherwise the blood pressure just keep increasing. So we need something to balance that. And what does that is something called atrial natriuretic peptides. So atrial suggests that it's released from the atria of the heart, and it's particularly stimulated by atrial stretch. It can also be stimulated by the sympathetic nervous system to be released. And then angiotensin 2 actually also stimulates its release as well. So it's part of that negative feedback process, very, very important. And then it causes natriuresis, which is excretion of sodium, diuresis, which is excretion of water, which is going to help to lower that blood pressure again. It causes vasodilation, the opposite of vasoconstriction, which is caused by angiotensin 2. Okay, so say for example, if we had a decreased blood volume, we're going to have a decrease in central venous pressure, a decrease in cardiac output, a decrease in mean arterial pressure. Yeah, and that's essentially how it works. If we go back to that original diagram what I had, that's a very good illustration of how all these neurohumoral factors contribute to blood pressure. Okay, and it's also just on a side note, the pituitary gland has a very useful it has a portal system which acts as a quick conduit for hypothalamic hormones to reach the anterior pituitary gland. You should have a look at the anatomy of that. It's quite interesting. But essentially, portal systems help certain substances to bypass the systemic circulation if they need to act on a specific area quickly. So let's move on. So let's talk about some definitions now. So we know that blood pressure is measured in millimeters of mercury. A normal blood pressure is roughly 120 over 80, but there is, um, room for variation too. Stage 1 hypertension is 140 over 90 to 159 over 99. Stage 2 is 160 over 100 to 179 over 119. And then stage 3 is anything equal to or above 180 over 100 or 120. So it can be, for example, so you might have a blood pressure of, if it was stage 1, you could have a blood pressure of 145, and that could still be 90, and you'd have to investigate that further. Okay, and then just a little side note: when we look at diagnostic techniques, because blood pressure is typically measured in GP, NHS health checks, every 5 years. I think it's after the age of 45 for the NHS health checks. Um, the GP might, for example, might find an abnormal read, and they want to, di um, potentially diagnose hypertension and do some further investigations. And we tend to use either ambulatory blood pressure monitoring, which takes lots of measurements of the patient's blood pressure in a day, or home blood pressure monitoring, which takes, I think it's 2 measurements over a couple of days. And then we can really gauge, whether the patient has high blood pressure or not. Okay. And the ranges for stage 1 hypertension, if you're using ABPM, for example, are slightly lower. So it's 135 over 85 to 149 over 94. And then in diabetic patients, when you're measuring blood pressure, stage 1 will be classed as 130 over 80. And then stage 2 in diabetics would be 150 over 95 or higher. So it's slightly less than what it would be in patients without diabetes. So, malignant hypertension is an important definition to understand. It's very important. It's hypertension with papilledema. Papilledema is essentially swelling of the optic disc. And if you looked on ophthalmoscopy, or sometimes it's called fundoscopy, you'd be able to see blurring of the disc margins. You might be able to see some lines called Patton's lines, which are concentric lines on the retinal surface around the optic disc. And they're kind of related to pressure changes caused by the disc edema. You can see some papilledema here, so you can see the optic disc, you can see blurring of the margins in particular. We also have another definition, so hypertensive crisis. So it's a BP of either greater than 180 systolic or greater than 120 diastolic. And this can be further categorized into hypertensive emergency, where there's evidence of end organ damage. So it could be kidney damage, for example, and the other part of the classification is hypertensive urgency, and that's where there's no evidence of end organ damage. So it's less serious, but it also requires that thorough investigation. And then masked hypertension is equal to a blood pressure of less than 140 over 90 in clinic, but the hypertension is present on the arterial blood pressure monitoring. Sorry, on the ambulatory blood pressure monitoring or the home blood pressure monitoring. So it's not present in clinic, but it's present on the ABPM or the HBPM, and that'd be the opposite of something called white coat hypertension. So the white coat hypertension is where the blood pressure would be high in clinic, but then when the patient's alone or doing their normal activities at home, it's going to be lower. So it's the opposite. Okay, so let's talk about primary hypertension. So primary means that there's no underlying cause. And let's talk about some of the risk factors. So it's back to these modifiable risk factors first. So things such as advanced age, family history, ethnicity, and sex. Typically, up to 65 years, men have higher blood pressure. After 65 years, women tend to have higher blood pressure than men. And then other non-modifiable risk factors such as well, oh sorry, these should be non-modifiable risk factors, and these should be modifiable risk factors. So other modifiable risk factors are obesity, excess salt intake, so you can reduce your salt intake, physical inactivity, so therefore you should exercise more, excessive alcohol intake, and stress. So this should say modifiable risk factors. All right, so let's talk about secondary hypertension, where there's an underlying cause. Let's talk about some of the differentials based on the different systems. So cardiac in particular, we have aortic coarctation. It's where we have hypertension in the upper limbs. And this is because you have, if we look here, we've got a diagram. See here, we've got kind of narrowing of the aorta. And in this case, it's postductal. So it's after the ductus arteriosus. So it's postductal here. It's preductal in this case, and it's like a congenital narrowing, and that's going to lead to hypertension in the upper limbs in particular, because all this blood here under high pressure is going to be diverted through these branches. On examination, the patient might have a left infraclavicular murmur, so systolic or continuous murmur, and they might also have an ejection click, because you can sometimes have an associated bicuspid aortic valve, and so in less than kind of in 10% of the cases, the first presentation can be subarachnoid hemorrhage because of aneurysm formation. So if you think you've got all of that blood under high pressure going to the cerebral arteries, it's going to put a lot of stress on the endothelium, lead to the formation of aneurysms, and then they could potentially burst and lead to the subarachnoid hemorrhage, and that's where you'd have the blood in the basal cisterns. If you looked at that on a CT image, and it gives that star-shaped pattern. Okay, and then in terms of renal disease, we have renal vascular disease, glomerulonephritides, pyelonephritis, and adult polycystic kidney disease. And essentially, why hypertension occurs in renal disease is because there's a reduced EGFR, lots of fluid overload, suppression of the RAS system, so the renin, angiotensin, aldosterone system, and there's a lot of proteinuria, so loss of protein in the urine, and that further worsens the fluid retention. Examples of renal vascular disease is renal artery stenosis, fibromuscular dysplasia of the renal of the arteries, all not good, and we're going to talk about them in a little bit more detail. And then in terms of respiratory, you have obstructive sleep apnea, and essentially in OSA you have increased sympathetic activity. When patients are transiently being aroused from sleep and they have disturbed sleep, there's increased sympathetic activity, and that leads to increased sympathetic vascular resistance, and then as a result, elevated blood pressure. And then certain drugs such as cocaine, amphetamines, all different types of stimulants, contraceptives, long-term steroid use, and then even drug withdrawal, particularly alcohol. And the reason why you can have high blood pressure in that is because you have hyperactivity of the glutamate system, particularly related to alcohol. And then there are also obstetric causes. So when you think about gestational hypertension, preeclampsia, and eclampsia, gestational hypertension is hypertension after 20 weeks of pregnancy in a previously normotensive woman, so a woman who's previously had normal blood pressure. Preeclampsia is a triad of hypertension, proteinuria, so protein in the urine, which can be picked up on the dipstick, and then peripheral edema. They might have ankle edema, the face might be swollen, etc. And then eclampsia includes the triad, but women also have it's characterized by seizures. Like you have to start involving drugs such as magnesium sulfate to try and prevent further seizures and reduce the severity of the seizures what they've had. Okay, and then when you're investigating secondary hypertension, you want to be suspicious of anyone who has these features. So anyone who's had a stroke, young patients, there's an absence of family history, sudden onset or worsening hypertension, treatment resistance, onset before puberty, and then an onset for 30 years, especially non-obese and no family history of hypertension. Okay, so I just want to mention some endocrine causes, so some hormonal causes, because there is quite a few. First, we have primary hyperaldosteronism, which is typically caused by adrenal hyperplasia and adenoma, which are benign, or carcinoma. If you were to look at the bloods, that you'd have high aldosterone, low renin. Then we move on to secondary hyperaldosteronism, seen in things such as renal artery stenosis, heart failure, liver cirrhosis, nephrotic syndrome, or renin secreting tumours. And essentially, the reason you'd have high aldosterone and high renin in heart failure and liver cirrhosis and nephrotic syndrome is because you have fluid displacement. You're going to have a lot of fluid in the interstitial space. Therefore, the macula densa within the nephrons will think that the blood volume is low. You have a low volume, so therefore you get a release of aldosterone after renin's released. Obviously, because that comes first in the RAS system. And then we've also got Cushing's syndrome. Cushing's, when you're talking about the syndrome, you're talking about the symptoms related to the elevated levels of cortisol. Cushing's disease is an ACTH producing adenoma of the corticotroph cells of the anterior pituitary. Pheochromocytoma, which is where you have increased secretion of catecholamines from benign chromaffin cell tumor. The chromaffin cells are located within the adrenal medulla. Liddle's disease, which you might not have heard of, which is also known as pseudo-hypoaldosteronism. So it's basically where you have continuous activation of ENaC channels, like I mentioned earlier, in the collecting duct. So your aldosterone's actually low, but you're having lots of sodium and water reabsorption, hence the name pseudo-hypoaldosteronism. And then something called congenital adrenal hyperplasia. So this is where you have it's basically a congenital disease where there's deficiency of particular enzymes responsible for producing certain hormones such as aldosterone, cortisol, and also androgens, so sex hormones. And the case where you have hypertension is where you have a deficiency of the enzyme 17 hydroxylase. And when you have a deficiency of 17 hydroxylase, you can't produce androgens. There's basically diagrams you can look at which illustrate this as well. You can't produce androgens down one pathway. So then the activity of the other pathways to produce other hormones increases. There's more activity, and hence you get an increase in the synthesis of aldosterone via other pathways, more sodium and water retention, hence high blood pressure. Because we wouldn't want to include 21 or 11 hydroxylase deficiency, because they wouldn't present with hypertension. Okay. And then acromegaly, which is where you have elevated levels of growth hormone. The hypertension is thought to be related to hyperinsulinemia, so elevated levels of insulin cause an increased sympathetic activity and activation of the RAS system. Thyrotoxicosis, so the hypertension and the elevated blood pressure in that is particularly related to the raised cardiac output. Remember the equation: blood pressure equals cardiac output times systemic vascular resistance. But we know in thyrotoxicosis there's reduced systemic vascular resistance. I talked a little bit about that in my um, heart failure video, where I was talking about high output cardiac failure, where the increase in production of waste products of metabolism actually from thyrotoxicosis, such as CO2, the peripheral vasodilators, so the systemic vascular resistance is actually low. But because you have that increase in heart rate and also heart contractility, therefore you have an increase in blood pressure because the cardiac output is increased. Okay, so let's talk about some mechanisms. Um, and it's known that hypertension is a risk factor for endothelial dysfunction, and it can result in coronary atherosclerosis, which increases the risk of myocardial infarction. I talked about that in my video on MIs, so check that out if you haven't already. So we have an increased systemic vascular resistance, or afterload. Um, we have certain compensatory mechanisms to the increased systemic vascular resistance. So the heart is going to have left ventricular hypertrophy to try and maintain its cardiac output, but hypertrophy leads to fibrosis and stiffening of the ventricle, which ultimately results in reduced contractility. Patients' baroreceptor reflexes also become less sensitive to changes in blood pressure, which isn't good. And then the kidneys have this mechanism called pressure natriuresis to basically try and get rid of fluid to lower the blood pressure, but this is also, not quite effective. Okay, and then blood backs up into the lungs, and the heart is unable to meet metabolic demands, and this can lead to congestive heart failure. You're following that that left ventricular strain and hypertrophy. Okay, let's talk about some neurological mechanisms. So there can be chronic stress on blood vessel endothelium. I've mentioned that already. And one thing we can have weakening of cerebral arteries and formation of aneurysms. Like remember I was talking about in aortic coarctation. In this situation, we also could have aneurysm formations, and they could potentially burst. If they burst, you can have so within the cerebrum, within the brain, you can have hemorrhage, and that can result in a hemorrhagic stroke. You can also have atherosclerosis, so fatty plaques within the cerebral arteries, which can reduce cerebral blood flow and cause an ischemic stroke, also very, very serious. And the chronic stress leads to that initial endothelial damage, which is kind of the first part of the process of atherosclerosis. And you'll be aware of that if you've watched my other videos. So I just want to talk about it's called a myogenic mechanism, which occurs within the afferent arteriole, um, within the afferent arterioles, um, within um, within that kind of nephron system. Remember, the afferent arteriole is the arteriole going towards the glomerulus, and the efferent arteriole leaves the glomerulus. And normally the afferent arteriole has a larger diameter than the efferent arteriole, and that creates a hydrostatic gradient. So particles can move into the Bowman's capsule. Okay, so that was just a little recap of the physiology. But essentially, you have the myogenic mechanism um, in response to increased resistance slash pressure within the afferent arteriole, and this aims to compensate for increased pressures, which could potentially damage the glomerulus and Bowman's capsule. So increased pressures seen in hypertension. And there are also metabolic mechanisms which I've mentioned about the RAS system, etc. And this is an autoregulatory mechanism. So this ensures that there's constant blood flow to organs despite changes in perfusion pressure or resistance. And this is also going to be important when we talk about the pathophysiology of hypertensive nephropathy. So how hypertension impacts the kidneys. So this is just for your own reference. There's a lot of complicated terms in here. I thought I'd include it so you can understand. But essentially, the principle is you have vasoconstriction, so constriction of that afferent arteriole to try and prevent uh, prevent damage to the glomerulus and also the Bowman's capsule. Okay, so this is basically how blood pressure affects the eyes. So you have increased pressure within the retinal vessels, and you have therefore hypertensive retinopathy. Um, I just want to put a pin in that because we're going to go back to that later in the video. And then we're going to talk about this pathophysiological mechanism of hypertensive nephropathy. So you have constriction of smooth muscles of the afferent arteriole, which is what we mentioned, to prevent the transmission of increased blood pressure to the glomerulus, because you don't want to damage it, because you have these really small fenestrations. There's lots of delicate structures. So the afferent arteriole tries to constrict to prevent um, this transmission of the increased blood pressure. And you also have this chronic stress on the endothelial and smooth muscle cells of the kidney. And you have eventual hypertrophy of the afferent arteriole. So this, because it's being constricted, eventually the muscle is going to increase in size, and this is because of that prolonged vasoconstriction. Because the body, um, adapts to changes such as the increase in blood pressure. You're also going to have a release of cytokines and hence matrix such as fibrin and collagen into the subendothelial layer. Hence, you're going to have thickening of the arteriolar wall and narrowing of afferent arterioles. Just definitely don't want that. There's going to be reduced glomerular blood flow, glomerular and tubular ischemia, because there's going to be less oxygen getting into the glomerulus and the tubules, which is going to result in glomerular sclerosis, so hardening, and atrophy, so shrinking of the tubules. And that's essentially the process of hypertensive nephrosclerosis. So it's similar to the way in which the left ventricle tries to adapt to high blood pressure. These are compensatory mechanisms, but um, they tend to be insufficient. And when we talk about the retinal vessels don't even particularly have an autoregulatory mechanism um, in first instance, so they tend to be the eyes tend to be the first organ impacted. So that's why it's so important to do fundoscopy, screening of the eyes for these pathological changes. Okay, so let's talk about some clinical features of hypertension. So they kind of tend to appear late, as the hypertension's progressed. But we have things such as headache, poor sleep, epistaxis, which we know is nosebleeds, hyperacusis, so ringing in the ears, palpitations, reduced visual acuity, chest pain, and if there was something like nephritic syndrome, we might have some hematuria, so blood within the urine. Um, and when we talk about secondary hypertension, the presenting features relate to the underlying problem. So if someone was to present with headaches, intermittent sweats, and palpitations, thinking along the lines of the tumor of the adrenal medulla, the pheochromocytoma. If someone has, weak femoral pulses, you might think more coarctation of the aorta. Um, if you're thinking along the lines of Conn syndrome, a patient might have hypokalemia, so they might present with tetany, muscle weakness, like a flaccid myopathy. They might also have polydipsia and polyuria. And then if they had some sort of thyroid disease, you might be able to examine them. You might find a goiter, changes to the hands. They might have a tremor. You might have, I don't know. Let me just think of something like increased reflexes. So there's lots of different things. So relating to the underlying condition. So it's very important you investigate that and examine them thoroughly. It's also important to think about the patient's comorbidities related to their risk of future risk of end organ damage. So let's talk about some diagnosis and investigations. So diagnosis, if there's greater than a 15 millimeters mercury between each arm, you're going to have to repeat the blood pressure. And still a 15 millimeters of mercury, 15 greater than 15 difference, use the arm with a higher reading for further readings. Okay, and if the blood pressure is 140/90 to 180/120, you want to offer them ambulatory blood pressure monitoring. And if that ambulatory pressure monitoring reading is greater than 135/85, as an average, you confirm the diagnosis of hypertension. And essentially, ABPM, you have two measurements per hour of a person's waking hours, typically between 8 and 10, and you basically average at least 14 measurements. So you're getting a very, very accurate reading throughout the day of how the patient's blood pressure fluctuates. Okay. And if the patient can't tolerate ambulatory blood pressure monitoring, they can have home blood pressure monitoring, which is essentially where blood pressure is recorded twice daily, in the morning and the evening. It's recorded for at least kind of 4 to 7 days ideally. And for each reading, there's two consecutive measurements. So you'd have two readings in the morning, two readings in the evening. And when you're kind of working out the average, you want to discard the measurements from the first day. That's just something which is done to improve the accuracy. And for all patients, you want to do albumin to creatinine ratios. So you're checking for that proteinuria. If there's any renal problems, also you want to do a urine dipstick test for hematuria. Bloods, again, using these similar to renal function. HbA1c, just glycated hemoglobin, and also cholesterols. So you can look at your total cholesterol and also your HDL. Want to examine the fundus of the eyes. 12 lead ECG. So you might see some left ventricular hypertrophy, for example. You also want to calculate the Q-risk score, so the 10-year risk of a cardiovascular event. And then these are additional considerations too. Might do a renal ultrasound, particularly a Doppler. You can look at the flow within the renal arteries if it's impeded. And these are all based on your underlying suspicion, following your history and examination. You might look at 24 urinary metanephrines if you suspect pheochromocytoma, urinary free cortisol. All this kind of relates to Cushing's, renin and aldosterone levels. When you're thinking about hyperaldosteronism, whether that's primary or secondary, plasma calcium. Can even do an MRI of the renal arteries. I think they sometimes do that in fibromuscular dysplasia, and echocardiography is a more sensitive and specific way of looking at to see if there's any changes to the actual chambers of the heart, in particular that left ventricle, looking for the hypertrophy. So let's talk about the physiology of hypertensive retinopathy. And like I mentioned earlier, so there's no autoregulatory mechanism in the retinal vessels, and you're going to have hypertension. So within that ophthalmic artery, which is the first branch of the internal carotid artery. So stage 1, which is mild/mild, You have acute and chronic vasospasm, and then you have diffuse, which leads to diffuse and focal arteriolar narrowing and vascular tortuosity. Stage 2 is more moderate, and that's where you can have thickening of the arteriolar wall, plus or minus sclerosis or hardening, and this compresses underlying venules. And this is known as AV nicking, not nipping, nicking. And then you can also see a red-brown light reflex. If you can see that, that's caused by arteriolar thickening, and this is known as copper wiring. And we're going to look at some examples of these on a fundoscopic image in a second. And then stage 3 is more severe. So when you have breakdown of the blood retinal barrier, you can have phlegm and blood hemorrhages forming. When you have serum proteins and lipids leaking from the damaged blood retinal barrier, this is known as yellow hard exudates. These hard exudates, they're quite distinct when you look at fundoscopy as well. And when you have occlusion of a terminal retinal artery, this causes fluffy ischemic lesions in the inner retinal nerve fiber layer, and this is known as cotton wool spots. And stage 4 is known as malignant. And you can have two things going on here. So you can have hyperpigmented patches surrounded by a hypopigmented ring, and this is due to retinal pigment epithelium clumping around particular. Sorry, I think this is clumping around ischemic choroid areas, and this is known as Elschnig spots. Don't worry about that one too much. Don't worry about that too much. But I've also got an image of that as well to have a look at. I've never seen that come up on any exams or anything like that, but it's good. It's good to know. And when you have ischemia of optic disc arterioles, this can cause blurring of the disc margins, and you can also have leakage from the arterioles, causing hemorrhage and disc edema or swelling, and that is known as papilledema. Okay, so here we have fundoscopic image in hypertensive retinopathy. And just particularly, I just want to mention in stage 3, you can have complications such as retinal detachment, vitreous hemorrhage, and also central retinal artery / vein occlusions. And they all have specific presentations which you may or may not be familiar with. So here we can see we have some retinal hemorrhages, like a dot / blot hemorrhage. We have some papilledema because we can see the blurring of the disc margin. We have these exudates, these small little yellow dots here. The cotton wool spots, areas of ischemic retina. We have some arteriolar narrowing. Remember, that's in stage 1. And some AV nicking, where the arterioles or arteries can compress the underlying venules, the smaller structures. And these are the examples of the Elschnig spots here. So, in terms of lifestyle modification, we look at improving, making dietary alterations. So, reducing the amount of saturated fats you eat, and looking at more healthy options, and the GPs can discuss this with patients. Looking at exercise regimes, and all these factors are useful in reducing blood pressure, smoking cessation, reducing sodium intake, and also trying to reduce your caffeine intake. Reducing your caffeine intake could also be particularly useful if you're experiencing palpitations, as increased caffeine intake before this. And like I said, all these factors aim to reduce blood pressure. So let's talk about the pharmacological management of hypertension. Very important that you know this. So if you're less than 55 years or have type 2 diabetes, you want to be started on an ACE inhibitor. Um, and then the next step would be to combine the ACE inhibitor with a calcium channel blocker or an ACE inhibitor with a thiazide-like diuretic. If you're greater than or equal to 55 years and you don't have type 2 diabetes, or you're Black African or of Afro-Caribbean ethnicity, we started on a calcium channel blocker, such as amlodipine. And the next step would to be either have a calcium channel blocker with an ACE inhibitor or a calcium channel blocker with a thiazide-like diuretic. Following on from that, you can have the addition of a third drug. So the typical combination patients tend to have is an ACE inhibitor, such as ramipril, calcium channel blocker, and a thiazide-like diuretic. Okay, and then in terms of the next step, if the patient's potassium is less than or equal to 4.5 millimoles per litre, you can look at adding a low dose spironolactone, which is a potassium sparing diuretic. If it's greater than 4.5, you want to look at adding an alpha or a beta blocker as the next step. And then if the patient's blood pressure isn't controlled on 4 medications, then you want to have a specialist review them and get that specialist opinion. Very important that you know this diagram. And then if the patient can't tolerate an ACE inhibitor, you can start them on a angiotensin receptor blocker, such as losartan. Sometimes patients can't tolerate the cough when they're on an ACE inhibitor. So these are just the blood pressure targets for patients less than 80 or greater than 80 in clinic, and also when they're having the ABPM or the HBPM. And this is just for your own reference. But yeah, thanks for watching. Hope to see you next time, where we're going to be talking about atrial fibrillation. I really appreciate all the support I get. Make sure to check out my Instagram for the links to my where you can basically, there's links to my PayHip profile where you can access my personal medical school notes. It's great to see that some of you have already done this. I hope that you find them useful, and feel free to um, to to give some feedback, because I'm always looking to improve my work. But with that being said, take care, and I'll see you in the next video.